I want to get us started perhaps with a little sense of place and time because for the work that I'm going to be presenting. Because I was sort of split between where I am now, which is Connecticut, and where many of you are, or at least know well, the University of Ottawa. Perhaps, like some of you, I've spent much of the past 2 years wondering, what does it mean to live well in an era of new to us infectious disease? The picture you're looking at, so again, to sort of get you centered or sort of grounded in some space, I took this picture on one of my many walks when I got back to Connecticut after spending the first 4 months of 2020 in Ottawa. This is the sun rising over the Quinnipiac River in southern central Connecticut, a mile or so from my house and a few miles north of the first reservation created in the lands that would eventually become known as the United States. This reservation was created in November of 1638 as part of the ongoing interaction between the Quinnipiac people, the people of the Longwater land who'd been here for thousands of years, the people whose name my university bears, and their interaction with the newly arrived English settlers. The creation of this reservation was likely a consequence of the socio-political instability brought to the region by 3 decades of epidemics: smallpox, diphtheria, flu, and measles. There are estimates that between 2/3 and 90% of the indigenous people in New England died in the early 1600s as a result of these diseases. Obviously, we're nowhere near that case mortality level with COVID. But there was a time, there was a window of time when we didn't know how bad it would become. Also, when we didn't have surgical or N95 masks, where we didn't have vaccines, we didn't have monoclonal antibodies, we didn't have effective treatments. And that window opened about 2 years ago. So about 2 years ago, as Colleen mentioned, I was lucky enough to land at University of Ottawa Center for Health Law, Policy and Ethics. And it was at the same time, and these are also pictures that I took on various walks, including one that was the walk down the hall each morning to my office in the center. At the time, we were starting to hear about a novel coronavirus with the first documented infections located in Wuhan, China. And to try to take myself back to this, to try to remind myself of what that felt like, I pulled a handful of headlines from that time, and it was jarring. And it remains jarring to look at headlines from those times because of the use of Wuhan virus or the coronavirus from China, Wuhan coronavirus. And this question, again, in January of 2020, this question was open of whether or not it would turn into a global epidemic. By February 2020, we had a name for the virus and the disease. The International Committee on Taxonomy of Viruses gave us the names that have become so familiar: SARS-CoV-2 and COVID-19. And yet, that official name, however, would not prevent some from using the virus and the disease as a tool to sow and fertilize seeds of othering, of painting some people as us and some people as them. At the same time, we were seeing COVID-related othering. We were also seeing a significant increase in reports in Asian American crimes. And so it was into this landscape, it was into this space that the work I'm presenting today started. Again, I was physically in Ottawa, but started to engage in, new to me then, Zoom calls and a lot of conference calls with a group of folks that I'd been working with for a number of years as part of the ethics committee down at the Yale New Haven Hospital in New Haven, Connecticut. At the time, we were an all-volunteer hospital ethics committee, and we were starting to wonder what policies, if any, we had in place at the hospital to allocate ventilators if demand exceeded supply. That group eventually published the protocol we adopted, One of the critical things to know, and so this is a wonderful group of people that I've had the opportunity to work with. We have on this group a number of clinicians. There are 4 of us who, however, were non-clinicians. Of those 4, 3 were legally trained. The 4th is very much a policy person. And all of us have had extensive experience and training in ethics. And so this is the group that was trying to put this particular protocol together. Of this group of people, when I saw how this presented itself graphically, I was reminded of the early Brady Bunch opening themes for anybody who still has that point of cultural reference. I'm the Alice in the middle. And similar to Alice, I'm not really a part of the family in the same way as everyone else. Everyone else is affiliated with Yale in some way, shape, or form, whether it's Yale University, Yale School of Medicine, or the Yale New Haven Hospital as their primary employers. I am a community volunteer on the ethics committee, and yet was invited and engaged in this work because it was really important to me. At the time that we were doing this, one of the first things we did was take a look at a bunch of the other protocols, a bunch of the other recommendations, and recommendations for standards, crisis standards of care. And one of the documents in particular that we looked at that I figured would potentially be new, at least to this audience, was a white paper that came out of the Connecticut Department of Public Health. And this was a white paper created in October 2010, in part informed by the prior 2003 SARS scare that the folks in Canada certainly felt a bit more than the people in the United States did in 2003. Even so, in hindsight and looking back on that, there was this group from the Department of Public Health that put together this white paper. And it was put together by a multidisciplinary group consisting from representatives from hospitals and long-term facilities, nurses, physicians, ethicists, emergency preparedness professionals, first responders, and healthcare attorneys. One of the things, so one reason why this particular white paper played a significant role in our work was because one of the people who was a part of this white paper was also a part of our drafting group. Steve Latham was that person who was sort of the bridge between this particular framework. One of the things that was fun to see, again, as I'm working on this in my small apartment near Bay and McLeod, was this reference and this appreciation for the department, from the Department of Public Health to the University of Toronto's Joint Center for Bioethics Pandemic Influenza Working Group, and the ethical guidelines that were put together, again, in hindsight after SARS. And when I was thinking about how did these protocols, how did these papers tee up any question about race? As we were putting this together, this report, the University of Toronto's report, had no explicit mention of race, but in fleshing out the substantive value of equity, the report advised that, quote, all patients have an equal claim to receive the health care they need under normal conditions. During a pandemic, difficult decisions will need to be made about which health services to maintain and which to defer. Depending on the severity of the health crisis, this could curtail not only elective surgeries, but could also limit the provision of emergency or necessary services. Connecticut's white paper did, in fact, have a single reference to race. And that white paper recommended that, quote, all policies or altered standards should be applied fairly and justly without regard to factors such as race, gender, ability to pay or payer source, social worth, perceived obstacles to treatment, or past use of resources. So despite the fact that these sort of foundational recommendations advised a kind of color blindness, a kind of disregard or a deliberate ignorance to race, our group, our drafting group at the time was very concerned about the potential implications and reality of the longstanding and well-known racial, ethnic, and socioeconomic disparities in health in the United States. As part of our drafting process, we presented questions to a community bioethics forum created and supported by my co-author and friend, Lori Bruce, to get thoughts and suggestions from a group of non-clinicians, community volunteers unaffiliated with the hospital, but likely to present to the hospital in the event that they found themselves in need of acute or emergency care. They represented a wider range of communities, backgrounds, and lived experience than our drafting committee included. And then once the triage protocol was approved, ultimately approved by our healthcare system's leadership, the system then created a broad-based triage advisory group made up of individuals representing the diversity of the health system's patient population across race, geography, sexual orientation, age, gender, ability, and socioeconomic status. Many of the people invited to be part of the triage advisory group were known leaders within their community, including faith leaders and community organizers. And many of these folks were on the boards of community organizations throughout the healthcare system's footprint. So that was sort of what led up to creating the protocol. Let me give you a sense of what the protocol included. So one of the most critical components here was a sense that triage decisions would be made by interdisciplinary teams separate from the team providing clinical care. That team's decisions would be based primarily on two core components. First, the Sequential Organ Failure Assessment Score, or the SOFA score. You'll hear me talking about this quite a bit for the rest of the presentation, so let me just give you a little bit more background on what the SOFA score is. It's a prognostic score originally validated in sepsis that ranges from 0 to 24 points, with points assigned for evidence of organ failure within 6 different organ systems. The higher your SOFA score correlates with a higher likelihood of in-hospital mortality. Critical to our later research, we worked with our hospital informatics team to develop and test an automated SOFA calculator within our electronic medical record. And that continuously calculated the SOFA score for every admitted patient in the healthcare system. In addition to the SOFA score, the triage protocol and the triage decisions would be based on the presence or absence of severe survival limiting comorbidities, so long as those comorbidities were expected to result in death within 1 year, regardless of medical interventions. And so overall, we were working with sort of a foundational score of up to 8 points, where 8 points would mean that you were the least likely to survive. And a score of 0 or 1 would be, or 0 or 2, 1 or 2, most likely to survive. To the extent that we were running out of ventilators would go to those who had the lowest scores, triage scores in this context. Now that fundamental score could then be modified based on 3 other criteria. One option was you might gain or lose a point based on the clinical judgment of the triage team, not the clinical team, that a patient was consistently improving or worsening in the past 24 hours. This would be based on a review of the medical record by the triage team. Pregnant patients who had a potentially viable fetus with a gestational age of greater than 22 weeks would potentially have their score improved by 1 point. And then patients who are healthcare workers, first responders, or hospital employees with repeated patient contact during the pandemic could potentially be bumped up by 4 points in this. And this sense of reciprocity was pulling forward some of the values from that University of Toronto's report, the Connecticut white paper on reciprocity, and was also something that we actively sought feedback and thoughts from our community bioethics forum before adopting. So that was the protocol that we adopted. How'd we do? Despite good intentions and despite process, how did we do? Well, on the upside, we never really found out. largely because our triage protocol was designed to be potentially triggered when the healthcare system had to officially shift to crisis standards of care. So this graphic is one from a report that came out in the middle of our protocol writing and our triage protocol writing. It came out from the Hastings Center, and I think it provides a helpful illustration of the difference between conventional ops, which I think what many of us are currently thinking of before COVID right now. The crisis ops was when triage protocols would have to be activated, and Connecticut and the Yale healthcare system have not had to trigger the protocol. We have spent most of the time these last 2 years, though, in this contingency ops space, where we're trying to make do and trying to do the best that we can with what we've got. Even so, a group of us decided to look at how the foundational component, the SOFA score, played out in our COVID patients from March 29th, 2020 to August 1st, 2020. To give you a sense of how the Yale, the demographics of the Yale New Haven health system, across our system, our patients are majority white, 61% white, 17% Black, 3% Asian, and less than 1% Native American, Hawaiian, or other Pacific Islander. But critically here, 19% are other or unknown race. And part of this is because of the challenge of capturing this data well. Add to that, our patients are 78% non-Hispanic, 20% Hispanic, and 2% of other or unknown ethnicity. Our results initially made it clear that we were clearly well-founded in our concerns about COVID perpetuating and potentially exacerbating long-standing disparities. Our study population, again, was drawn from consecutive patients aged 18 and above, admitted with COVID between March 29th and August 1st. Here where you see of the 2,982 patients admitted with COVID during this time, only 2,300, a little over that, met the inclusion criteria. For folks who were excluded, it was either because it wasn't their first admission with COVID, or they didn't have a SOFA score recorded within 24 hours of admission. This could occasionally happen on our weekends when our system wasn't automatically updating. Or if race or ethnicity data were not non-Hispanic Black, non-Hispanic white, or Hispanic, or if they had other missing data. We were afraid that we weren't going to be able to get statistically significant results with our Asian, Native American, Hawaiian, or other Pacific Islander groups. Critical to this is to understand and to see that, again, disproportionately, the folks being affected by COVID in this time were our populations of color. So while 61% of our patient population is historically white, less than 50% presenting or admitted at this time were non-Hispanic white. Comparing our 17% Black community population, 26.6 of our admitted COVID patients were non-Hispanic Black. Of our 20% Hispanic population in the greater population, 27.8% admitted were Hispanic. And so it was clear that COVID was taking a disproportionate toll on our communities of color. And in addition to that, of folks who were admitted, non-Hispanic Black patients had greater odds of an elevated SOFA score. So remember, if you have a higher SOFA score, you were going to have a higher triage score and be put to the end of the line in the event that the protocol was triggered. Add to that, we then examined the associations between race and ethnicity and the peak overall SOFA score while someone was a patient, was admitted as a patient, and we compared that to the in-hospital mortality and ICU admission of those patients. Critical component here, while Black patients in this sample of hospitalized COVID positive patients had higher SOFA scores, this did not translate to higher in-hospital mortality or ICU admission. So the SOFA score was not an accurate predictor of likelihood to survive. using the SOFA score, had we had the potential to exacerbate existing racial inequalities by disproportionately denying care to Black patients. So we tried our best and clearly came up with a failed protocol. As I was preparing last night, I revisited some of the other photographs that I took while I was in Ottawa. I came across these 3 pictures of the brilliant beadwork by Cree artist Ruth Cuthand that was on exhibit at the National Gallery of Canada before it and the rest of the museums shut down in March of 2020. The exhibit notes at the time read, quote, Cuthand's intricate beadwork series depicts diseases that affected Indigenous populations after their forced dislocation to reserves and the resulting changes to their traditional ways of life. These works examine a paradoxical feature of trade between Indigenous and European peoples during early colonization in Canada. Prized, colorful beads arrived alongside diseases that decimated many Indigenous populations. At once enticing and repellent, these unflinching works create a space for reflection, close quotes. And with those notes, I then noticed that you can see a sort of a failed selfie of sorts of me in each one of these, where you see the reflection of me taking the picture reflected in the glass overlaying the beadwork. And my colleagues and I from the drafting committee did publish some reflections that are available following up on our Journal of Clinical Ethics publication of the protocol itself. That said, what I want to provide you now are some of my current reflections on the work that we did. First, one of the things that was absolutely critical was working with the informatics team early so that we had data to evaluate whether ethical intentions were effective. However, this data and these electronic medical records aren't capturing all of the allocation decisions being made in contingency stages. And so we're struggling to find the data that will capture those less formalized, less documented kinds of decisions. We had an early focus on stuff and space, but what we're realizing now is we will not be able to rely in the future on having separate teams, especially of our senior clinicians, to step back and be on these triage teams. So we're trying to think through how else we might allow clinical care teams to focus primarily on patients as opposed to resource allocation without making decisions based on overbroad categories, limited data, and implicit biases baked into both. Also notice that emergencies inherently carry with them a sense of scarcity in terms of time, potential, or personnel and resources. It's a difficult time to be advocating for deliberation, new relationships, or nuanced decision-making. The work to identify and actively mitigate existing disparities and implicit biases remain critical work for the in-between times. It is hard to do it, and it is hard to do it well in these emergencies. Given the longstanding underrepresentation of Black, Indigenous, Latinx, and rural communities in our healthcare workforce, we still have a lot of work to do to revise our sense of reciprocity for any future allocation decisions. And these research projects and our ongoing quality improvement efforts have been largely unfunded. This is work being done on goodwill. The people working on them are doing so because they have a genuine interest in the work and have been able to carve out time. But that kind of burden should not be placed on communities that have already been overburdened with this kind of research. So with that, I look forward to your thoughts and questions when we get to discussion. Thank you so much.
Jennifer, thank you so much for that terrific presentation and reflection on your experience, which I think really helps us to truly see the problems of trying to do the right thing and sometimes ending up doing the wrong thing. So with that, and I look forward to the Q&A with you as well, Jennifer, shortly. We'll pass the baton, as it were, to Monnica for her reflections now.
Yes, thank you for that wonderful presentation. And now I'm going to talk a little bit about some of my research on implicit racial bias and Black mental health and the implications for people of color in Canada surrounding COVID-19. So I don't need to spend too much time introducing myself after that wonderful introduction from Colleen, but just to say that I am a psychologist and a researcher, and I've been studying mental health disparities for some time, especially around issues of race and racialization. And so today I'm going to be talking, as I mentioned, about implicit bias, which I know is a big buzzword, and you may have heard that term before. And sometimes it's used correctly, sometimes not. So I'm going to just define that for us as well as we go. But first, I want to talk a little bit about disparities in Canada and the US. And so here are some examples of disparities. Black Canadians face several inequalities or inequities compared to their white counterparts right here in Canada. So white university educated men have life expectancies 14 years higher than those of Black men without a high school education. Black Canadians have a working poverty prevalence over twice that of white Canadians. The unemployment rate among Black Canadians is higher. 1 in 15 young Black men in Ontario have been in jail, compared to 1 in 70 young white men. The prevalence of household food insecurity among Black adults is almost 3 times the prevalence of white adults. And Black women are 27% less likely to have completed high school compared to white women, and we're 21% less likely to have completed university. The situation is not so much different in the United States, where we see, for example, that the median net worth of Black households is less than 15% that of white families as of 2019. The poverty rate for Black Americans is more than double that of white Americans. Black American employees are 60% more likely to be uninsured than white employees. Black Americans account for 23% of COVID-related deaths, despite representing only 13% of the population. Home ownership rates for Black Americans much lower than white Americans, and food insecurity much higher as well. So again, we see inequities. Now, when it comes to race and health in Canada, this report called Color-Coded Healthcare found that non-European immigrants were twice as likely as Canadian-born to report deterioration in health subsequent to immigration. Moreover, Black immigrants were 76% more likely to assess themselves as unhealthy than other racialized groups. So there's something about race that's connected to feeling unwell here in Canada. Research on the impact of racism suggests that living in a racist environment increases the risk of illness for racialized individuals. And there are many reasons for that. But one of those reasons is that racialized people experience racism in their interactions with the healthcare system, which may in turn have an impact on access to healthcare and life-saving screening procedures. So consider that if you're a racialized person and you go to see the doctor and you have a bad experience, maybe the doctor makes some stereotypical assumptions about you or treats you with less respect, you're going to feel less like going to the doctor again, and you're going to be less likely to follow medical recommendations. Worse yet, doctors might make poor medical decisions based on assumptions about you just because of your race. So we do have these problems right here in Canada. They are not as well documented since many organizations and municipalities don't collect ethnic or racial data. And we think that some of those problems are due to what we call implicit bias. Now, implicit biases are primarily unconscious in nature, so people aren't always aware of these biases, or they're maybe not usually aware of them. So these are, again, these unconscious positive or negative attitudes and stereotypes held toward somebody from your, what we call, racial outgroup. And these can automatically influence how people react and behave in subtle ways toward other people. And we sometimes refer to these subtle racist acts as microaggressions. And these behaviors are pervasive. We see them in children as young as 4 years old. Now, your explicit biases these are your conscious positive or negative attitudes and stereotypes, which you have easy access to. For example, if I was to ask you whether you had any positive or negative attitudes or stereotypes toward Black people, whatever answer came to your mind would be consciously accessible. And so that we would call those explicit attitudes. However, you also have deeper thoughts, beliefs, and schemas within your unconscious that may or may not even match what you explicitly hold. And so these are your implicit biases. And although these implicit and explicit biases are related and sometimes reinforcing, they are distinct constructs and may or may not be correlated. So most research to date focuses on the direct impact of implicit bias on mental health disparities. And that's because it's easier to identify the direct impact of an implicit bias when they come from, say, primary healthcare providers. We can look at things like differences in diagnoses or treatment decisions and health outcomes, and we do see these differences. In mental health, research focus has been on differences in access to the quality of care for people of color based on implicit biases. For example, there was a study that came out a few years ago by Kuglemas called "Sorry, I'm Not Accepting New Patients," which was an audit study of access to mental health care. And what they found was that a white middle-class woman, this was done in New York City, had to call 5 therapists to get an evening appointment offer, whereas a Black working class man had to call 80 therapists. So if you're that Black working class man, I don't know about you, but I think most people would give up before they called that 80th therapist and not ended up getting the mental health care that they needed. Now, few researchers to date have looked at the indirect impacts of implicit biases. So anti-Black implicit biases carried out by the general population are thought to have an impact. And these biases are held by not just white people, but also non-white people. And this has an impact on the mental health of Black communities, at least that's what we believe. But little is known about these biases, particularly here in Canada, where we don't do as much research on this. And also there's not much known about the differences between Canada and the US. And so this was one of the things that our research team was interested in looking at. And so this takes us to our most recent study, which was aimed at understanding the indirect impact of implicit biases on Black mental health. And so these were 3 of our research questions. To what extent does implicit racial bias within various groups or to what extent does it exist between various groups toward Black people in the US and Canada? Do rates of implicit bias differ between ethno-racial groups in Canada compared to the US? And then what role does this play on mental health indicators in Black populations? So we use the Black-White Implicit Association test. You may be familiar with it. You may not be. It's considered a gold standard approach for measuring implicit racial biases. And it looks at people's reaction time when pairing faces, Black faces versus white faces, to positively valenced words versus negatively valenced words. And that time differential is what's used to calculate the bias score. And so we use this test to ascertain white and non-white American and Canadian anti-Black bias levels. And so this is a freely available test. It's online as part of a project called Project Implicit. And so people all over the world take this test all the time. We were able to access the data from 2019. And after cleaning the data, we had almost 500,000 participants. Now, the vast majority of these were American, but there were actually enough Canadians that we were able to do some statistically valid comparisons because the sample was just so large. And the scores range between -2 and +2, where -2 would be having a very, very strong Black bias, and +2 would be having a very strong white bias. I mean, nobody gets like 2, but we consider scores between over like 0.3 to be moderate and over 0.6 to be strong. So and 0 would be someone who has no bias at all. So that's how we score it. And we also compared this to the U.S. Centers for Disease Control's WONDER database, and this stands for Wide-Ranging Online Data for Epidemiological Research, which has data for all different types of conditions and outcomes. And so we look specifically at drug-induced causes of death, alcohol-induced causes of death, and suicides. And so these were 3 of the main mental health indicators we examined. And we were interested in finding out how implicit bias might relate to differences on those indicators regionally. Now, in answer to our first question, to what extent does implicit racial bias exist within various ethno-racial groups toward Black people in the US and Canada? Here's a graphical representation of what we found. Basically, anything over 0 that's positive is an anti-Black bias. And what we found was basically most ethno-racial groups have anti-Black biases. The only group that kind of didn't were, well, like Black people, which were kind of closer to no bias. And then in this group here, Native Hawaiian or other Pacific Islander, in Canada, they didn't really have much bias, but this was, I should qualify, that was like a very small sample. So, but by and large, for the most part, for most groups, the biases were pretty much the same or close enough. These were actually, because of the large sample size, most of these were significantly different, but they were not effectively different. When you looked at the effect size for most of these, they were pretty much near identical. So I know in Canada we feel like we're like less racist and less biased than our neighbors to the south, but the data doesn't really show that. Okay, now our second finding is, do rates of implicit racial bias toward Black people differ between ethno-racial groups? And of the 9 groups considered, only 2 had different implicit bias levels between Canada and the US. And that was the East Asian and multiracial groups. And for those 2 groups, actually the anti-Black bias was higher in Canadians, although again, the magnitude of that effect was really, really small. Now, we looked at this and we broke it up by US state and made this heat map of implicit biases by states throughout the United States. And what you can see here is that, some regions had like a lot more bias than other regions, with the red being more biased and the green being less biased. But keep in mind, even the green is biased because by and large, on average, there was bias. And we wanted to see and we looked at in those states what the, again, what the suicide rates were and the drug and alcohol induced mortality rates. And what we found is that even after controlling for the mortality among white people and controlling for explicit bias, we found that implicit bias did significantly predict suicide rates and Black drug-induced rates. So something about implicit regional bias was contributing to Black mortality above and beyond these other factors. Now, we did also look again at alcohol-induced mortality, and that model was statistically significant as well, but the bias score was only marginally significant. It was like P equals 0.051. With an additional 9% of the variance accounted for by implicit bias, but it just missed significance. So we said it's like sort of a trend towards significance. So as a whole, it's pretty clear that these regional biases do contribute to mental health problems, right? And so you may be asking, well, what does that mean really? And how we interpret that is that, well, first of all, these regional implicit biases predict worse mental health outcome among Black people in the United States. And and what we are hypothesizing is a possible mechanism for this, and certainly there's probably many causes, but we believe that implicit biases held by clinicians lead to poorer medical health care, refusal of care, as we saw with the Kugler study, or even fatal medical decisions to the detriment of Black people. And there are research studies that support that all of these things happen. Now, we couldn't conduct this analysis with the Canadian data, as regional mortality statistics are not freely available by race. And also the IAT data, they don't collect it or report it by province, although we could probably ask them to. But the bigger problem is just that the racial data isn't out there or easily gotten to do this analysis. However, due to the similarity in findings of bias between Americans and Canadians, we think the situation is like pretty much the same here. Now, in terms of how this relates to COVID-19, it's clear we know that racialization puts people at higher risk for infection for a variety of reasons, including that people of color are more likely to have like public facing jobs or be required to work as essential workers, or they don't get paid time off of work for being sick, for things like this. But even so, we see that the COVID-19 mortality rates have been 2 to 3 times higher in Canadian neighborhoods with the highest proportion of visible minorities compared to those with the lowest proportions. And this has been especially true in Ontario, Quebec, and BC. And so failing to collect the racial data, however, hampers our ability to study this problem more directly in Canada. And there have been calls to start collecting racial data. But we do believe that implicit bias is a factor in the quality of care that patients of color receive, contributing to increased pandemic mortality. Now, and what I'm not saying here is that I don't think doctors and nurses are saying, okay, we're going to like intentionally deprive people of color of the care that they need. But keeping in mind that these processes often, they operate outside of awareness. And so these things can happen even without people intentionally meaning to mistreat others. And so that's, and clearly more research is needed, but thank you. That's all I had to share today. And here's my contact information for anyone who would like to reach out for me or for a copy of this article that is now in press. So thank you.
Thank you so much, Monica. And I would invite everybody, if you have questions, to please put them in the Q&A. Jennifer, if you're able to come back on screen as well, nice to see you again. Terrific presentation, Monica, and very sad and sobering as well. I guess, I know, Monica, you are only relatively recently arrived in Canada. I wonder about the problems that you've mentioned a couple of times around accessing data that better describes what is happening from a racial perspective in terms of allocation of healthcare, and why is that? Often what we hear is that populations that have been historically discriminated against and currently discriminated against are perhaps sometimes reluctant to share their data. Is that what is the main problem, or is this a problem that the powers that be are just not collecting that data? And I'd also appreciate your comments on that too, Jennifer. I think we know from epidemiological perspectives, that having the data is the most important thing for galvanizing change. Otherwise, we can all sort of play the smoke and mirrors thing about, you haven't really shown us this, or we don't really know, or maybe. So, Monica, are you able to, it's a tough question, but are you able to address that?
Oh yeah, absolutely. So the fact of the matter is, like most people, like if you ask them or if you have a question on a forum, they're usually going to answer the question. You always are able to have an option, prefer not to answer. And a few people are going to check that. But if you ask them, they're going to answer for the most part, especially if you explain why you want the data. And if you make it clear that this is because you want to make sure that, for example, the healthcare resources are being distributed fairly, most people can get behind that. And people of color will be glad to answer the question for that situation. Where you see like a little more hesitancy is, for example, job applications or situations where they feel like it may personally come back to bite them. And even in those cases, you can sort of mitigate these fears if you make it clear that people are not going to be penalized or judged negatively for how they answer those questions. But I think the bigger issue really is that a lot of people feel really uncomfortable asking these questions, particularly white people who tend to be raised to and are taught from an early age that the way to be anti-racist is to not talk about race. And so when asked to do anything that has to do with anything that involves race, many white people are uncomfortable. And so then they don't ask the questions. And it's a lot easier to say, oh, people don't want to answer those questions than to actually do the hard work of figuring out what's the best way to ask the question. And also, like you said, if we don't have the data, then people can't be held responsible for not making their services equitable. So I think there's also some additional reasons why there hasn't been more of a push for this. And I don't know if you want to add anything, Jennifer.
A lot of wholehearted agreement. I think one of the things in particular when we were looking at, I don't know if you remember from the data that we had 19% of our patient records that lacked racial or ethnicity data. And when we were trying to dig through to find out the why don't we have it? So we have it in our medical record. It is something that's supposed to be collected. It is that combination of the folks at intake. There's a question of whether or not race is being assigned by someone on intake, as opposed to asking the question. There's also this, as a result, some of that discomfort that Monnica was talking about asking the question. And so for some of our folks who are responsible for intake, how comfortable do they feel asking about race? And then there's this the two additional components of that concern that if race is flagged in some way, shape, or form, there may be concern about what that means. And so any potential blowback, especially in a patient record. And so the system that I'm working in, we have a shared medical record across inpatient and outpatient settings. And so that question of whether or not reporting something in a hospital, it's also going to be accessible if you try to become a patient or access care elsewhere in the system. And so that becomes a concern. And then lastly, our current categories don't necessarily capture what people identify as. And so when you have a none of the above, it's a none of the above. And so that just becomes one of the ongoing challenges down here, at least, of trying to figure out what should our census categories be collecting. Because even when we were trying to figure out how should we be evaluating our data, what data should we be looking at, and how should we be running our analyses, and then even how should we be publishing our results, we were really stuck in trying to figure out, do we stick to the census framework? How close is our current medical record system to the census data? And if we start changing those to better reflect folks' sense of self-identification, what's our ability to actually compare things longitudinally anymore if those categories start to change? And so those are some of the arguments and concerns that I heard and run across in the context of this particular project on how and why to get that data.
Yeah, I would just note here too, another work I'm doing on artificial intelligence, health-related artificial intelligence. One of the big issues that everyone is wrestling with is the problem of algorithmic bias and the concern that the creation of artificial intelligence, which by necessity is built on the data that is available and fed into the machine, one hopes that a machine would be, colorblind, but it only is as good as the data that it receives. So this, the concern is that it can perpetuate or stagnate or keep in place the bias that is extant in the diagnosis and treatment of people right now. So this problem of data would seem to be a really, really important one for us to, for society to address. But I guess my sort of, if I can ask the kind of $64 million question of both of you, if you ruled Canada, not that I'm not sure that anyone actually does. It's a bit of a melange of rulement. But Monica, what are the sort of most important things, and Jennifer, what are the most important things that need to happen now to really address this? I mean, the disparities are gross. This is a tragedy. What would you recommend that happens in Canada? And Jen, you too. I mean, you're both Americans, but have spent a lot of time in Canada, and we're doing our best to turn Monica into a Canadian. Can you help us think about this really big challenge?
Yeah, absolutely. So first we have to collect the data. I mean, it just has to be mandatory that these health organizations are collecting the data. Collecting the data in and of itself isn't going to solve the problem, because I can already tell you what we're going to find, and it's not good. But we have to have some place to start so that we can track improvement, and also, more importantly, hold organizations accountable. And I think that right now it's too easy to just throw your hands up in the air and say, oh, the problem's too big and I don't know what's wrong and it's not my fault. But each unit, for example, in a health system can be held accountable for the quality of care that people of color are receiving in that unit. And so, as soon as you start attaching these outcomes to people's salaries and promotions and so forth, you're going to see big difference. But right now, nobody's being held responsible. So I think that's where we have to start. And the other thing is we have to really look at diversifying the medical workforce. And I know that there's always some efforts being made to do this, but they're always like too small. And we have to look at like our graduation rates from our medical schools, our nursing schools, our psychology programs, and those programs have to be held accountable to graduating students that match the diversity of our country. And again, no accountability means nobody's going to put effort into it. So,
okay.
So
yeah. Greater accountability incentives.
Yes.
Okay. Jennifer.
I again, a tremendous amount of agreement with that. One of the other components that I might add to that is it will take a lot of time to get good data. And things are bad enough right now that we likely shouldn't be waiting until we have the data. And so trying to think more broadly about, I guess in my mind, I think there's often a chunk of this, and this was, again, an ongoing discussion, and it continues to be an ongoing discussion with the people I work with who've been in this work now for 2 years, of intention is not impact. And so you can do your absolute best to try to do the right thing, but it is critical to see if you're successful at it. And if not, admit it, let people know that you have failed and that we still need to grow from it. I think that whether it's, I'm most familiar with the law and medical sort of spaces of the sense of perfection is critical. Yeah. And so there needs to be some work in our professional cultures to sort of acknowledge quality improvement is an ongoing process and that we are all works in progress. And so working towards that underlying reality of, and part of that I think is a mental health component upstream idea as well, of realizing everyone is a work in progress. Mm-hmm. And there isn't a better or worse. at this point in time. There are people along a continuum, and they're along a continuum for their entire lives. So where you meet someone now is not where they're necessarily going to be, and where they have been is not necessarily predictive of where they're going to go. And increasingly an understanding of that. But again, so I think one of the other significant challenges that we are struggling with is even trying to figure out, again, how do you collect the data on on truly those contingency decisions, the whether or not to admit someone. If you admit someone, to what floor? Which floors are better staffed and poorly staffed when you are starting to run low on nurses? What is starting to get lost in communication when you no longer have visitors by the bedside and you're starting to lose the communication about patients? And how is that playing out in terms of increased or decreased trust within our system? Those get to, I think, some of, again, a lot of the concerns that Monnica raised of, if you've not had a good experience with healthcare, there is also inherently going to be a lag to seek care the next time. And as a result, one of the challenges that I know we've seen down here in some of the early works, trying to work with outcomes measures and trying to adjust them for communities that care for and treat disproportionately poor communities, is there is a concern that bad outcomes might actually be reflecting the sort of the disparate health of the population coming in, and not necessarily the quality of the care in the place. And so it's also just really complicated trying to allocate those incentives and disincentives and any penalties to make sure that you are in fact able to calculate the care, as opposed to the sort of additional and historical challenges that any single community is navigating before they even hit the healthcare system.
Right. Okay, yeah, that's a very important point about how you structure those incentives, Jennifer. So you don't want to structure incentives to actually encourage healthcare providers to further avoid providing care to racialized populations. So we have a couple of questions in the Q&A. So I'll ask the second one first, I think, which is how have BIPOC populations, so Black, Indigenous, and other visible minority groups, reacted to triage protocols? So how have those groups reacted to them? So not just the academic reaction, but the groups themselves. The commentator says, compared to disability groups, my impression is that they have not been as outspoken about how triage can possibly affect them, unjustly deprioritizing them. So I wondered if we could get comments from both of you on this. Jennifer, shall we start with you? Have you heard in your work from the groups that are impacted themselves?
Not directly. I think part of my thinking about this, I can't help but place in time the role of Black Lives Matters, right? So they really hit sort of the national radar, at least in the U.S., during the summer of 2020, when there was this heightened concern about this potential for triage. And so I think there has been historically, it's been kind of challenging, and it was tough for a while to actually get a copy of any of these triage protocols to know truly how things were being allocated in order to have a popular reaction. But again, given what we know about infectious disease facilitating socio-political instability, historically it did this time too. And so that's where I can't help. I have not heard anything directly targeting the triage protocols themselves, but just in the larger ongoing dialogue of needing to make sure that we're not inherently in all contexts and in all places deprioritizing Black and Indigenous lives especially, but also Latinx and Asian populations in both the US and Canada.
Okay, thank you very much. Monica?
Yeah, I would say I think most people of color don't know that there are these algorithms, and but when they learn about them, they're very upset. But I can tell you, for Black people in the United States and many other of the marginalized communities, they already anticipate that if they go to the hospital, they will be deprioritized. So they wouldn't be surprised to learn about this, and a lot of them know that they are going to have to advocate for themselves if they want to get equitable care.
I think to the extent that this had been studied before COVID hit, there were some studies done in Maryland with communities and trying to get a sense of allocation of ventilators and trying to think through a first come, first served versus some sort of lottery versus some other kind of allocation. I think this was one of the results from that study that we talked about quite a bit, was the fact that at that time, in that situation, the Black community was asking for a first come, first serve. And that result was quite different from other folks who were looking for a lottery. And there was this question of to what extent would a first come, first serve kind of allocation protocol, in fact, reward insiders, folks who knew to come to the hospital sooner, folks who knew the system to get admitted earlier or get on the list sooner, and grave concern that in our particular community, that would be less likely to be our Black communities. And so we had that data coming into it and ultimately decided that that was not going to be one of the rules that we were going to incorporate into the protocol.
Mm-hmm. Okay, so there's another question in the chat. It's quite a technocratic question. And the question is, what are your thoughts on the use of area deprivation index to incorporate an equity factor into triage algorithms as suggested by White and Lowe? So I don't know if you've thought about that, Monica or Jennifer, or either or both of you.
I would be a little cautious about using something like that. I mean, for one, even we're using these areas and neighborhoods as proxies for racialization, but the fact of the matter is most people of color in Canada are not low income. Most people are middle income. I mean, there's many more low income people, but if we just sort of base it on, do you live in a poor neighborhood, we're still going to end up with with problematic decisions and outcomes. And so I certainly think that we need to take this into consideration. I don't think that that's going to really be the best way to figure it out.
That's again, just the broader concerns about how data is collected and what it in fact reflects, and this concern about creating overly broad categorizations that aren't in fact reflecting the needs. It may be some of the best data we currently have on how to think about it. I still struggle when we're getting to, as my colleagues did, and I know a number of our current care team members care, it's the difference between a protocol and an algorithm versus an individual decision for a patient, and trying to figure out how do you actually look at the patient in front of you versus what the numbers suggest this patient should be. and again, that was part of the reason why procedurally we were hoping that we would have triage teams to make a lot of decisions, was to sort of take that conflict away from the clinical care team so that they didn't have control over the resource allocation question. But what we're seeing now, quite frankly, with the pressure that we have on our system at the moment, compliments of Omicron, is we don't have people to pull back from our clinical care teams who are qualified to be able to make those triage decisions. Because we had that at the beginning of COVID, because before there were vaccines and before we had PPE, so many of our senior clinicians were advised and agreed to step back from clinical care. And so we had this fantastic workforce of incredibly wise and experienced people who could be in those conversations, even though they weren't providing clinical care at the time. We just don't have those people anymore. And so trying to figure out how do we separate that tension between the protocol and the data versus the individual patient for the clinical care providers who are so trained to care for the patient in front of them.
Mhm.
And trying to think through to a lot of what Monnica was saying, that data is not going to capture the everything of the person in front of the particular care team. And I just don't know how that would play out with the mental health, frankly, and the wellness of our current healthcare workforce.
I think with COVID-19, it's relatively rare, thank goodness, in healthcare in developed countries like Canada, the US, where you actually have a hard resource constraint. Mostly the resources are there somewhere and just need to be pulled together. But with COVID-19, because of the intense pressure on hospital resources, a relatively low number of hospital beds per capita that both Canada and the US have, relatively low number actually of physicians and healthcare professionals per capita that both the US and Canada have relative to other jurisdictions. The Omicron, but even with Delta, huge pressure on these systems. I wonder, and I know that this is a very difficult question to answer, but how should we approach issues then of allocation? Now, you've talked, Jennifer, about the problematizing it with the work that you did, but how do we take that forward? And Monnica, you too, we know what the disparities are and the problems are, and that clearly, as I would sometimes say, Black Canadians are getting the rough end of the pineapple here in terms of resource allocation. So, but where there's a tight constraint and a limited number of respirators, beds, ambulances, how should we allocate that care? When I teach my course on healthcare systems, I actually start with, and Jen's helped me teach this first class, I get them to try to figure out how would they think about allocating a scarce resource, and I give them some options and they have to vote for it. So for an option, so they could allocate it through the market, they could allocate it through a lottery, they could allocate it through democracy, they could allocate it through some kind of technocratic assessment of quality adjusted life years. They could allocate it on the basis of past contributions or potential future contributions. And, the students have to pick one, and they hate this, but I make them pick one. They kind of hate it and they love it because, it feels sort of real. And now clearly, with the work that Jen did and the good folks at the Joint Center for Bioethics have done in the past, there's a tendency, and a lot of the students vote for these kind of technocratic, kind of colorblind modalities, right? You add up some numbers about quality adjusted life years, or potentially, which would generally favor children, young people, healthy people, and you don't have to think about disability or race or any of these issues. So what do we do here? And I'm sorry, Monnica, because of course, it's not for you to solve this problem for the rest of us. But I wondered if you had some thoughts on how we should think about this, and like right now, how should we be thinking about the allocation of care for Canadians in the face of Omicron?
Yeah, I mean, It is something that you have to think about, even though I kind of feel like, oh, maybe the ethicists should figure this one out. But I know that often people do make decisions based on, well, how much useful life do you estimate this person has left? And I think that that's kind of a dangerous metric really to go by, because for one, we already know that people in racialized communities have shorter lifespans because of racialization. And so you're going to put the most disadvantaged people at the back of the line, which I think if we step back, we can kind of see that that's not fair. And then some people have even said maybe the people with the most disadvantage should go at the front because they've had to deal with all the disadvantage for the whole rest of their lives. Maybe we need to be thinking about some reparative goals here. So I don't think that that's a bad solution either. I don't really have a clear answer for what we should do, but I can see why so many Black people, like Jennifer said, wanted the first come, first served approach, because it's very transparent, and even though it may be unfair for a number of different reasons, it makes sense to people. And when you have sort of a more complicated algorithm, I think it's going to make a lot of disenfranchised people feel very uncomfortable, because there's sort of more room to hide bias in a plan like that. That's all I have to say. I don't have any answers.
Fair enough. Jennifer?
I think one of the things that's just been bouncing around again since March of 2020, and when we're talking about COVID and we're talking about care, we have been, in my mind, sort of stuck on the data that we have, and the data that is relatively easily captured, like deaths, like hospitalization. It is rare that I see the full discussion of excess deaths as opposed to COVID-related deaths, to actually start factoring in the mental health component and the role of mental health in health writ large. And so I think we have, again, this is because we are working from the data that we easily have. And here I will definitely defer to Monnica, but my impression and my sense is that it is tough to get good data on how mentally healthy people are. To then be able to crunch, and what is the trade-off of a shutdown? And what is the trade-off of higher intensity treatment versus keeping 10 people out of overdose and 10 people out of the hospital because they're feeling mentally healthier, and so they're not engaging in higher risk activities. They're able to continue to sustain themselves without taking the higher risk behavior that's getting not just more COVID, but also more of the things that end up in our hospital anyway, car accidents and overdoses and alcohol poisoning and suicide attempts. And so that's just one of the things where, moving forward, I think before we have any more of the data, trying to be a bit more mindful about the mental health reality of how and what people need to stay alive. In addition to and in collaboration with our data on the actual illness of COVID itself.
Right. Although, what I see, Jen, myself, is that this is, without good data, it's it's politicized.
Yeah.
So people who don't like shutdowns and public health precautions talk mental health. Right, you're wrecking the mental health of everybody, ignoring the mental health of the people who have suffering, their families of the people who have died, who are mostly racialized. I mean, there's mental health on both sides of this. So I think, to go back to our very first question, this issue around data is so critical, because it seems to me that whether you're talking about public health precautions and who wears the hard end of those, and letting COVID rip and who wears the hard end of that, on both sides of these, it seems likely that it's primarily BIPOC populations that wear it. So, perhaps we need to really think this through and have very clear data about what the result is. We don't have too many any more questions coming in the Q&A. So I think, and we need to close actually in a couple of minutes to let people go students that are here need to rush off to their 1 o'clock classes and, virtually rush off. So rush to the bathroom and rush back again. I wanted to thank you both very much for this really engaging conversation. I wondered if you had any last words, Monica or Jennifer, before we formally close.
Yeah, I think, in addition to the issues that I discussed, I do think that we need to invest more in healthcare here in Canada. I think we need more resources so that when things like a pandemic happen, we're not stretched so thin that we can't help anybody. And so, having been a consumer of healthcare on both sides of the border here, certainly there's a lot to be proud of here in Canada, but we do need to, I think, bring our system into the 21st century and start covering more things and putting more of an emphasis on preventative care as well, which saves money and misery down the line. So that's my 2 cents.
And I think part of that is this in my mind, again, just sort of from this work and sort of a high level $64 million kind of thought is, how much efficiency can we afford and how much equity can we afford? Right? Part of that investing, it's ideally we would have both, right? Ideally it would be both, not wasteful, and it would be well stewarded resources that is equitably available to all. However, I think one of the challenges and one of the tensions is efficiency is frequently easier to measure in many ways. And so we tend to lean towards that. And we tend to look for return on investment in terms of the returns we can measure and the investment of what we can measure. And equity doesn't necessarily get captured empirically as well as the money and the diagnosis and the treatment and the utilization of stuff. The role of people is much harder to capture, I think, in that space. And so there are so many times, and there have been so many times in the past 2 years when I have just been struck by how quickly many people are trying to think. And I just keep coming back to fast thinking versus slow thinking. And fast thinking, in my mind, and again, here, I will completely defer to Monica if I misunderstand this. But in the fast thinking space, the efficiency kind of rules, the utilitarian kind of rules tend to govern a lot of that. And again, the biases that also get packed in tend to be in that thinking. And that's exactly what that sense of scarcity and shortage tends to foster and facilitate. But for a lot of this, we need slow thinking. And so how do we create space, and how do we measure, and how do we factor in the slow thinking part of it? We tried with our protocol to at least have that little bit of giving the triage team at least a little bit of wiggle room to actively dig into the file to look. And we tried to think through the reciprocity component. And we didn't get it right, but we tried. And then we measured to realize we didn't get it right. But that slow thinking, trying to figure out how do we better facilitate that, because I struggle to see how equity will happen well and often without more of the slow thinking space actively created.
You're absolutely right. And one thing we know from the research is that when you're short on time, when you're tired, when you're under pressure, those implicit biases are more likely to rear their ugly heads. Whereas when you have space and you can think about it clearly, you can make decisions to overcome some of these urges to be biased. And so absolutely, when everybody's under the gun and you're trying to make fast decisions, you're most likely to get it wrong.